Okay, we've come to the final chapter in the trauma section, and this chapter, chapter 42, is multi-systems trauma and trauma resuscitation. So this is kind of really a tie up the loose ends of trauma in this chapter. Not a terribly long chapter, just a handful of pages with a handful of objectives, but I think it's a good summation of what we've covered in the trauma section to this point. And as with all of our chapters, you must read and study the chapter on your own. Simply watching and listening to the lecture is not enough. So if you haven't done that, do so at your earliest convenience. Last time we'll probably see this one. The education standard is the advanced EMT applies fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely injured patient. Objectives you will find all on 926 and 927. All right, so when we're talking about multi-systems trauma, we're generally talking about patients who suffered a significant injury or a significant event and had a very significant mechanism of injury. And in most cases, well, in any case in which we have multi-system trauma, we're talking about patients who have injuries to more than one body system. So we could be talking musculoskeletal, with some fractures and sprains and strains and whatnot, maybe a little bit of a pneumothorax caused by one of the fractures in the ribs, which is going to involve the respiratory system, and perhaps even punctured a spleen or so, and now the cardiovascular system is involved. So when multi-system trauma occurs, the morbidity and mortality is increased. It raises exponentially for every additional system that is included in the traumatic injury. There's another condition, and I think we maybe have just mentioned it one time, that it's called multiple organ dysfunction syndrome, MODS. Multiple organ dysfunction syndrome kind of goes with ARDS, which is adult respiratory distress syndrome. But multi-organ dysfunction syndrome, once you hit 3 systems that have failed, you are almost guaranteed to die. It's got a well over 90% mortality rate. So, same sort of thing applies here with trauma. So much higher morbidity and mortality. So the AEMT must consider the overall impact of the multi-system trauma. You've got to manage the immediate life threats and then begin transport to the closest appropriate facility. The second and third items here really should have been a theme throughout the entire trauma section if you hadn't picked up on that we manage life threats. There's not a lot we can do with a lot of the other traumatic injuries, because number one, it's hard for us to see inside to know exactly what's going on, and number two, we just don't have the skill set to manage all of these things. So, managing the life threats, of course, the ABCs, the supportive things that I continuously talk about, is got to be paramount. And then rapid transport. Outside of getting called to some isolated injury that we kind of, probably honestly didn't need to be there in the first place, but we got called, so what the heck. We got called to the ball field, somebody slid into base, broke their leg. I think most of us probably would not call 911 if we had broken our leg or one of our family members had broken their leg. We most likely would have opted to transport them via private auto. Those sorts of things. Time is not particularly of the essence in most cases, unless we have, a limb threat. So if the neurovascular bundle has gotten impinged upon and now we have no pulses and whatnot, yeah, that makes it a little bit more high stake. But in most cases, this is a nice, easy assessment, treatment, and transport into the hospital. So again, we're gonna start every call. We're gonna start with our scene size up. I mean, we've got to be aware of what's going on the scene, and it really gives us the most tone for the overall issue. So we perform our primary assessments, we do the interventions for any ABCs. That hasn't changed. It doesn't change. So, if we need to put in basic adjuncts, we need to ventilate patients, we need to start them on some oxygen, we need to push on the chest, we need to defibrillate them, or we need to control any severe and major bleeding. That all has remained the same. No changes there. Consider the need for manually restricting cervical spine motion or doing manual C-spine immobilization. Remember, that needs to go along with airway whenever possible. Now, sometimes it's just not possible. Sometimes we try to maintain an airway, trying to do a jaw thrust, and it just doesn't work. So it's life over limb. But when we can include it, when we can do the spinal immobilization as well as airway management at the same time, that's really ultimately what we're shooting for. Performing a rapid trauma exam. Remember, your rapid trauma exam is a once over head to toe, checking to see if there's anything that is a neon sign flashing in our face. Hey, look at me. Hey, look at me. I need your attention. This is not the inch by inch, crevice by crevice, hole by hole look at the person's body. That is the detailed or the formal head to toe assessment that you would do on somebody. But that rapid trauma assessment is basically, if we have a multi-systems trauma, we show up, we do our scene size up, primary assessment, any major interventions, make our patients naked, do the once over to make sure, hey, yep, we got it all covered. There's nothing going to jump out and scare us on this one. There's no hidden bullet holes or stab wounds or anything. We package our patient as indicated by MOI, and a lot of that is also going to depend off of what our local protocols are. Perhaps we still have protocols that say, you know what, you've been in a traumatic incident, you're getting immobilized, period. Or maybe as time goes on, we start to see more evolution in assessment-based spinal immobilization. And then transporting without delay. If you don't have to extricate somebody or extract somebody, which could mean, somebody's fallen in the basement of their home and it's going to take extra hands to get them up the stairs and around the bend in the staircase and over the rail and so on and so forth. If this is an easy walk-in, put them on the cot and get back to the ambulance, you have no reason to be on scene longer than 10 minutes. You get them packaged, and you get them going. In the multi-systems patient or the severe or critical patient, now granted, if we're talking about that, ouch, I hurt my ankle at the ball field, that's a different story. But transport without delay to the most appropriate facility. And I can't emphasize that enough. And there's still a lot of, there's really probably 2 or 3 major issues with transporting the most appropriate facilities. Number one, we have a lot of old guys around on the departments. It's like, by God, we've done it this way for 100 years, which they haven't. They haven't had an ambulance that long, but we've done it this way for 100 years, and we're not going to change it now. And that's just stupid. That's just regressive. That's just regressive EMS. EMS is a progressive field. Whatever the fire science and fire service wants to do, they can do whatever. But in EMS, we're progressive. We adapt and we move forward. Secondly, we have medical directors that have started to raise a stink. Actually, they started raising a stink a long time ago, and they just have never wisened up and said, hey, get them to the most appropriate facility. And then thirdly, we may have health systems. We may have some political issues that are going on in a community that's stopping this. And it's our duty to work to solve these, and because we're ultimately all here for the same reason, and that's for the best, what's best for the patient. So it's something we have to keep in mind. All right, so you think about it here. That goes with your case study. All right, so our goal on scene is initiate transport as soon as possible. Remember, in trauma, they talk about the golden hour. In EMS, We talked about the platinum 10 minutes. We try not to be on scene any longer than 10 minutes. Work as a team to assess, treat immediate life threats, package the patient for transport. Yes, you may be the highest level EMS provider on scene, but that doesn't mean that your EMRs and your EMTs can't do stuff. I mean, EMTs know how to package patients. EMRs know how to put oxygen on people. So you might have to kind of dictate, you might have to kind of run the show, but remember, it's a team approach. And a lot of times, even if we have to talk about extrication and whatnot, we're going to have to look at saying, hey, fire officer that's in charge here, here's my greatest concern of who I would like to get out of the car first and get transporting. I don't care which way you do it, just get access to that patient. And then managing AVCs, preparing for further care and transport while you wait for a patient who needs to be extricated. So with that being said, we say start your IVs on the way to the hospital, start your IVs on the way to the hospital. If you can climb into a car with a patient who's going to be a 10, 15, 20-minute extrication, you can get oxygen on them. You can get a lot of your assessment done on them. You maybe can do some bleeding control. Of course, you've got some C-spine under control, and depending on the situation, probably not putting a KED on them, but perhaps. But you could start some IVs on this patient while they're sitting there in the front seat. I know of times that I've started IVs in vehicles while waiting for 20, 30, 40-minute extrication. I've given medications to patients in vehicles. I've given airways to patients in vehicles. So there's things that can be done. It's all a matter of time management. So you look at those things. At the very least, if you didn't start your IVs in the vehicle, maybe you get them ready and they're hanging from the ceiling of the ambulance. So as soon as you roll right on in there, you can start those IVs because they're ready. You don't have to spike bags and whatnot. So your scene size up continues to be your first priority. It is our own safety and our partner and other responders' safety is our major concern. Because a lot of times these do end up being fairly unsafe situations and scenes. Do not attempt to access the patient until all hazards are controlled. The vehicle is stabilized, the gas is shut off, whatever. Because there's plenty of things, maybe it's even road control. And then requesting additional resources. Request these early because a lot of times it does take time to get there. Most of us have worked probably in a volunteer capacity at one point or another in our career, know that from the time the pager goes off, the ambulance doesn't roll out the door usually in 30 seconds. In most volunteer settings, we're talking at least a couple of minutes, and probably in reality looking at 5, 6, 7 minutes in many cases before ambulances roll out the door. Okay, career departments. It's very possible that those career departments get out the door a little bit faster. However, if you're in a career department, you're probably in a much busier setting. So the likelihood of a neighboring ambulance, a neighboring fire truck or heavy rescue or hazmat team or whatever being out is a little bit higher. So the sooner we request resources, the better. Particularly if we're working in a rural setting. So if we already are taking 5 minutes to get out the door, waiting for everybody to respond to the station, and then we have a 10, 15, 20 minute sometimes response time to the scene, sometimes it makes better sense to kind of get the ball rolling ahead of time. Just because you say, hey, let's start a second ambulance that way, if your system is set up correctly, that ambulance can start driving that way. They don't have to go 1,000 miles an hour, lights and sirens, but if they're already headed in that same direction, it's going to save some time if you show up and say, oh yeah, this is a bad deal, I need another truck. So looking at those things, putting helicopters on standby, making the ER well aware of your situation. Hey, it's going to be 20 minutes before we're at your door. But just thought we'd let you know we have a severe trauma patient. You may want to activate your trauma services. Maybe your system has a trauma alert system. So those sorts of things are great ideas. And it is all system dependent, depending on where you serve. Scene size up, you can care for only one critical patient at a time. So you're going to have to know what your policies are, what your procedures are, who can drive, who can accompany you. I've worked in some systems in which, it was routine for having our first responders drive for us, BLS units drive for us, law enforcement drive for us. So because they were kind of covered under our umbrella policies and whatnot. Can we handle 2 patients in an ambulance? Yeah, 2 patients that are not critical we can typically handle. So if you responded with 2 EMTs and you have 2 critical patients, you kind of got one on each and somebody else is going to have to drive. So if ALS is available, consider requesting them according to your protocol for critical trauma patients. Granted, there's not a lot of things that paramedics do different than AEMTs do. I mean, yes, they start some IVs. We have a couple of cool painkiller drugs, but we might have to paralyze a person and put an airway into them. We might have to pop a needle through their chest to decompress their tension pneumo and let that air escape. We might have to do a cricothyrotomy, which means cut a hole in their neck because we can't establish a decent airway on them. So there's a few things, but if nothing else, having a second set of hands and a second opinion is always a good idea. So determine the most appropriate facility, whether you live in an area that you have a selection. Maybe you have a level 3 and a level 4 and maybe a level 1 or 2 down the road a little ways. You got to know kind of where you're at. Know your own territory and say, okay, from where I'm at, what's my closest hospital, and how soon can I be in a upper level trauma center. Determine the best way of transporting a patient. Again, it's going to be very system dependent. In most cases, transporting by ground, it takes about the same amount of time as going by air, provided the patient is immediately available. If the patient is not immediately available, it's going to take a little while to get there. It's going to take some extrication or whatnot. Then perhaps aeromedical rescue is the best way to go with that. So you're going to have to know who you have around. In the people that we have in our class, we have some people that are served by Mercy Air Care out of Sioux City. We have some people served by Mercy One, either out of the Clarinda area or out of the Des Moines area. There's Lifelight out of Des Moines. There's LifeNet that covers the Omaha, Council Bluffs region. So we've got several different services, and you're going to have to know kind of what are their flight times to your areas. So again, paying attention to those things that you have to get outside of class. And I wish we could what if this to death, but it's just not possible because every situation is so different. So gathering as much information ahead of time is going to make your job much easier. Good example of multi-system trauma here is a lot of highway speed motorcycle collisions, just because there is so little protection for most patients. We look at that mechanism of injury that can lead to a multi-system trauma. Ejection or partial ejection from a vehicle, pedestrian struck by vehicles, falls from a height greater than 10 feet in an adult or twice the height of a child, motorcycle and rider separation in a motor vehicle collision. I just count that as ejection, period. Motor vehicle collision greater than 40 miles an hour, explosions, and multiple penetrating trauma injuries to the head, neck, torso. So using that MOI, you're going to help determine the need for manual stabilization of the head and neck. I'm going to tell you, if you're dealing with a multi-system trauma patient, it's probably just a good practice to expect to immobilize them. Once in a while, something will pop up and you'll say, oh, okay, well maybe we don't need to on this one. But it should be basically your initial instinct to immobilize them, and then occasionally have somebody prove your instinct wrong. Primary assessment. Manage the life threats before moving on to the other components. Remember that it's so easy to get distracted by something that's cool, as I like to call it. You know, if you have somebody's femur that's bent at a 90-degree angle in the middle of the femur, you know, that's going to be distracting. You're going to be paying attention to that and not paying attention, you know, maybe to airway and breathing and circulation. Granted, that's potentially a circulatory problem because we know that you can lose, you know, 1,500 to 2,000 mLs of blood into each thigh. But so pay attention to the ABCs first. Again, it emphasizes teamwork. And patients with trauma to the face or neck may also have inadequate airway. Remember, things such as chest and neck trauma, we may have interruption of their airway or their ability to breathe due to a hole in their respiratory system. So they may be sucking air in, and it's very possible that something gets pulled into a large vessel, or they have a sucking chest wound, or they have a pneumothorax. So occlusive dressings are potentially an immediate need. So taking your hand and slapping it over, that gloved hand, slapping it over a hole in the neck or the chest can potentially be a game changer for you. Be prepared to clear the airway manually and with suction. So with that, occasionally we're going to need to get, you know, our stack of 4x4s, wrap a 4x4 around our finger, of our gloved finger, and sweep the mouth out because there might be dirt, there might be grass, there might be teeth, blood clots, garbage in there. So clearing out the bigger stuff with your finger, and then the suction. Yes, nobody likes suction, nobody wants to clean the suction, but it's a critical piece of equipment. Using manual airway maneuvers, basic airway adjuncts, and eventually working your way into an advanced airway as needed. If you cannot establish an airway, request a higher level or start the transport without delay. Do the best you can and meet up with somebody who can use some other techniques. You know, there's a lot of times that multi-system trauma patients have clenched teeth, and you're not going to be able to get an oral airway into them. And if they have facial trauma, you're probably not supposed to use or probably shouldn't use a nasal airway on them. So in those cases, that patient might need to be paralyzed. Watch the LOC, and because the LOC will often be your first key to determining whether or not they are able to maintain their own airway. And they change rapidly. So be constantly paying attention to them. If this is a multi-system trauma patient, you should basically consider them unstable, and they get that every 5-minute recheck. Now, just because you may only be checking every 5 minutes doesn't mean you don't pick up on other signs. Changes in, you know, them becoming a little bit anxious or somnolent and sleepy. Maybe we're watching their pulse ox, and their pulse ox is dropping, their heart rate's elevating. We can pay attention to some of these other things that will key us in, and then pay attention to that adequacy of their breathing. If their ventilations are inadequate, consider what the cause might be. Is it a decreased responsiveness? Is it an airway issue? Is it a traumatic brain injury? So are we starting to see some irregularities, some weird patterns in their breathing? Spinal cord injuries, you know, has something happened to their phrenic nerve and no longer can operate their diaphragm? Chest wall, do we have a flail segment? Is there the potential that we've lost lung sounds on one side now and they have a pneumo? Cover any open wounds immediately with an occlusive dressing, wounds to the chest or the neck, either of those. And if you suspect a tension, call for ALS or transport without delay. We'll take a big 14 gauge long needle and stick it through their chest wall and let that extra air out. Assess the pulse, determine whether that perfusion is adequate. Immediately control any external hemorrhage, severe external hemorrhage. There's always going to be seepy-weepy little wounds, of course. Yeah, they're a pain, but anything that's squirting or flowing quickly needs to be controlled. And we're going to start with direct pressure. Remember, direct pressure will take care of most external bleeding, but you have to apply the direct pressure, and sometimes for upwards of 5 minutes to do that. Some people get so impatient that they think, well, you know, I slapped this dressing on here, I've been holding it forever, and it's actually been 60 seconds or so, and like, well, won't stop bleeding, so what are we going to do now? You understand, some bleeding takes up to 5 minutes to stop, so you're going to have to be patient. You're going to have to maybe consider a pressure dressing. Have somebody else, you know, if there's a bystander standing there, if you can say, here, put these gloves on and come over here and hold this, they can do that, if, you know, provided that they can stomach it. You know, you use your resources. You know, grab a cop, say, hey, I need your help, come over here and hold this. And if you can't control it, consider immobilizing, and of course a tourniquet as an option as well. Keep the patient warm. If we're suspecting them to be shocky, and if they're a multi-system trauma patient, basically they are going to get shocky. If they're being shocky, keep them warm. So, you know, we put them in an appropriate position, which in most cases is supine and immobilized on a backboard. Keep them warm, give them oxygen, airway control and ventilation as necessary. Control the bleeding, start with direct pressure, work our way to a tourniquet, cover them up with a blanket. So transport decisions. Critical trauma patients need to be transported to level 1 or a level 2 trauma center without delay. Or transport to a closer facility for immediate intervention and stabilization before transport to a level 1 trauma center. Depends on your situation, of course. You know, if you are 45 minutes at best from a level 1 or level 2 trauma center, then transport to a local facility. Unless for some reason it's going to be a delay in getting access to this patient or getting this patient out, and you're going to have a helicopter on the ground in a short amount of time, get them transported to the closer facility where there's extra sets of hands. That's one of the things that we're disadvantaged at, was we don't have all of the skill and we don't have all of the hands. So granted, that hospital you're transporting to might only be a level 3 or a level 4, but they at least have extra hands and they have a higher level of skill than we do. So it's not optimal, but you know, that's I guess the risk that some people take when you live in the rural settings, is you're a little further away from specialized services. Consider air medical, and then use the Center for Disease Control Field Triage Decision Scheme, or the National Trauma Triage Protocol, and which you will find in your textbook on 931, and it looks like that. So it helps us to make quick decisions on how critical is this person. So if we look at things that their Glasgow is less than 14, systolic blood pressure less than 90, respiratory rate outside of 10 to 29 breaths per minute, or less than 20 in an infant, then that indicates that these are a severe trauma patient. Take them to the closest level 1 trauma center if at all possible. If they don't meet that criteria, then you look and assess the anatomy of the injury. So you look for things such as penetrating trauma to the core, flail chest, 2 or more long bone fractures, crushed, degloved, or mangled extremities, amputations proximal to the wrist or ankle, pelvic fractures, open or depressed skull fractures, or paralysis. You identify any of those, take them to the local or to the closest trauma center, preferably, you know, a 1 or a 2. If they don't qualify there, assess their mechanism. So we look for things such as falls greater than 20 feet for an adult, or greater than 10 feet or 2 to 3 times the height of a child. Intrusion greater than 12 inches or at the occupant site, or greater than 18 inches anywhere on the vehicle. Ejection partial or complete. Death of a passenger in the same compartment. Or vehicle telemetry data is consistent with high-risk injury. Auto versus cycle, or being run over, or auto versus pedestrian. Greater than 20-mile-an-hour impact, or a motorcycle crash. greater than 20-mile-an-hour impact. Transport to the closest trauma center, depending on your system. Not necessarily the highest level trauma center, but if you have access to them, great. And then finally, if they didn't meet criteria in step 3, we look at 4. Those over the age of 55 or children should be triaged appropriately. Anticoagulation or bleeding disorders, burns without other trauma, and transport them to a burn facility. With trauma, trauma trumps burns, so they go to the trauma center. Time-sensitive extremity injuries, such as they have lost a pulse in that extremity. End-stage renal disease requiring dialysis, pregnancy greater than 20 weeks, or just your general gut feeling. Contact medical control, consider transport to a trauma center or a specific resource hospital, and if not, then transport according to your protocol. This is just a nice way to make sense of what we already know. A lot of places will have this posted in their trucks, and that's fine. But I think all in all, we know this. We know these things. We can put 2 and 2 together and say, yes, this is severe. We need to go to a trauma center. So more examples of life-threatening conditions: inadequate airways, ventilations, suspected pneumos, flail segments, significant external hemorrhage, suspected internal hemorrhage, decreased levels of consciousness, penetrating trauma to the head, neck, torso, or proximal extremities, amputation proximal to the wrist or ankle, combination of trauma with significant burns, 2 or more long bone fractures, suspected pelvic fracture, signs and symptoms of shock. Any of those things are indicating quick transport to the highest level center that we can probably get them to. Rapid trauma exam. This is our secondary assessment. This is our quick once-over head to toe. We're preparing our patient for packaging, so if we haven't made them naked by now, we make them naked. We get them immobilized, appropriately packaged with padding and straps and head immobilizers and whatnot, get them loaded and get going. So on the way to the hospital during our secondary assessment, we're getting baseline vital signs, pulse oximetry, completing a head to toe as we have time, getting a medical history, performing any other monitoring techniques that we have at our disposal. And again, reassessing every 5 for critical, every 15 for non-critical. Like I mentioned, you have a multi-systems trauma patient, you most likely are going to have a critical patient. Remember, during reassessment, we're looking for trends. We're looking for conditions that are slowly changing, and that's why it's important to have multiple sets of vital signs. If we don't have multiple sets of vital signs, we can't identify that their blood pressure is dropping and their heart rate's rising. And advise our receiving facility of any changes in that patient's condition. So you maybe gave them an early heads-up report, and now on your way into the hospital, things have changed quite a bit. Let them know that. Let them get the right resources headed that way. All right, if you feel that you're becoming overwhelmed or uncertain about how to proceed, take a deep breath, systematically reassess your patient. Begin with the patient's airway, then the breathing and the circulation. Sometimes we just have so much going on that we just get to the point in which we're not sure which direction to go with this. And it's okay to stop, and it's okay to step back for a moment and look at, what do I actually have here? Is this actually as bad of a deal as I think it is? Or in reality, is this maybe a worse deal than I think it is? That's okay. People do that. Remember, when you're packaging, the use of long spine boards in most cases are the most appropriate way to splint everything, and then until you have time to handle the little things. If you suspect spine injuries, C-collars, head immobilizers, manual C-spine immobilization until the point in which they're secured to the board. Stabilize the extremities by securing them to the body using backboard straps. And then, as time and resources allow, splint en route. Yes, it would be great if we had time to splint everything perfectly, dress and bandage everything perfectly. That's not practical. That doesn't happen when we have severe critical trauma patients. Additionally, it is improper to allow fractured extremities to move freely during packaging and transport. So sometimes we have to do this via some manual techniques. Sometimes the patient kind of self-splints these things. But ultimately we're going to get them immobilized at least with the whole body splint of being long spine board, and maybe perhaps with additional splinting as time allows. Those free moving extremities cause additional injury, they cause extra bleeding, they cause a lot of pain, and they can actually increase the patient's level of shock. Some principles of resuscitation. Critical trauma patient is at a high risk for shock. The more systems involved, the greater chance of shock. Shock leads to cellular hypoxia and death, and our goal is to maintain that adequate tissue and cellular perfusion to prevent irreversible organ damage. That's really what we're fighting against. Now, it's been a long time in class since we've last addressed shock as a whole, because that was towards one of the very first sections we covered it when we really got to patient care at the beginning of medical emergencies. So kind of recapping shock will maybe help run that back through your mind and help you recall the physiology and the pathophys of that. So in order for patients to survive, they have to have adequate blood volume, adequate number of red blood cells to do the carrying of the oxygen. They have to have a significant cardiac output, so their heart has to be pumping appropriately, and their vessels have to be of the appropriate size. They have to have a decent blood pressure. They have to be ventilated and oxygenated and have internal and external respiration. So there's a lot of actual components to this, and we're trying to maximize on those by treating the patient for shock and caring for their various wounds and their various injuries that they may have. Once a hemorrhage is controlled, IV fluids can help restore some of that vascular volume. The oxygen carrying capacity, however, can only be improved through red blood cell infusion. So they're going to need a hospital. Paramedics do not start blood in the field in most settings. There may be an occasional experimental setting they do, but in reality, paramedics do not have the ability to type and cross and do all the appropriate screening. We don't have the equipment to give them blood in the field. So that's why getting them to the hospital quickly where they can be appropriately screened and then given a blood transfusion. So if we give them a couple liters of fluid, we may help fill up their pipes. However, the amount of actual oxygen carrying capacity hasn't really improved. We've just made it slightly better for the fact that there's more transport medium for those red cells to move around in. In patients with an internal hemorrhage, bleeding is inaccessible except through surgery. So again, the trauma patient ultimately needs a knife. I've said that throughout the section. So increasing the blood pressure increases that rate of blood loss, in addition to other complications of fluid administration. So we have the patient that has a cardiac history and is a trauma patient. We run the potential, we run the risk of putting them into congestive heart failure. So our fluid administration increases the mean arterial pressure, and our goal should be to improve the tissue perfusion, and the MAP should be somewhere around 60 millimeters of mercury. Intravenous fluids will raise the blood pressure. It will increase the blood pressure, come at the cost of increasing bleeding, hemodilution, or making the red cells more diluted, and potentially hypothermia, because in many cases the fluids that we carry are probably closer to 70 degrees or so, whereas the body temperature is 98.6 degrees. So we will give them a slight disadvantage with high amounts of fluid give them 2 or 3 liters of 70-degree fluid, it's going to throw that balance. So that we can actually cause a little bit more harm. We can cause them to become a bit more hypothermic, have more heat loss when we have cold fluids. Now, if you're lucky enough to have a fluid warmer in your truck, great. Maybe it's not only a winter thing. Maybe it's also something that should be considered for 9 months out of the year, if not all 12. We're looking to achieve a balance between increasing the blood pressure in the severely hypotensive patient and avoiding the worsening of their condition. And I've mentioned this before, that back in the olden days, it was, give them all the fluids you want. Just keep dumping fluids into them, because that's what we're gunning for. We need to get their blood pressure up. And we know now, obviously through science, that that wasn't necessarily the best way to handle that. So what we do is we do that permissive hypotension again, where we try to keep their systolic blood pressure somewhere between the 80 and 90 millimeters of mercury range, unless they're a head injury patient that we suspect has an increased intracranial pressure, and then we're going to shoot for about 100 systolic. The IVs that we should be considering for trauma patients: large bore, 16s or 14s if we can get them, short needles, 1.25 inches, or 1 inch sometimes, depends on who your manufacturer is. Start 2 if you can. Normal saline or lactated ringers. Don't use D5. Remember, it's hypotonic, and therefore it's not going to stay in the vascular space. Consider giving them boluses of somewhere between 250 and 500 mLs at a time, and then recheck their blood pressure and recheck their lung sounds. Keep an eye on their lung sounds, particularly in your older patients and those patients that maybe have a little bit of a cardiac history. If the blood pressure remains inadequate after that first bolus or 2, try another, then reassess. So it's constantly a reassessment process there, where you give a little and recheck, you give a little and you recheck. And then follow whatever your protocols are for maximum volume of fluid for infusion. Most places are probably saying 2 to 3 liters should be the max that you should be giving a patient, and that's probably pretty appropriate. If you have a little bit longer transport times, perhaps you might be 3 to 4, but in most cases 2 to 3 liters of fluid is going to be plenty. Pneumatic anti-shock garment, PASG, or the mask pants. If you didn't get a good dose of these in your EMT class, we'll chat on them here just a little bit longer here. Those of us that have been around a long time, and we were originally EMT A's a couple of decades ago, this was a big deal. This is one of the things that really changed the curriculum for EMS at the time, was the mask pants, or the PASG. So the pneumatic anti-shock garment still remains controversial to this day. My entire career in EMS of nearly a quarter century, these have been controversial. One day they're the greatest thing since sliced bread, the next thing, people are saying don't ever use them, they're terrible. A lot of EMS agencies have removed them. There's not a lot of good science that actually backs them up. One thing that they are good for is they are a good immobilizer. So if you have massive lower body trauma, pelvis, legs, and whatnot, they are great to immobilize those massive fractures down there. Not to mention, they can also provide immediate direct pressure for you. So if you can slap on some dressings, and then you have the mask pants on, you pump the mask pants up, they're putting direct pressure on, more or less a big pressure dressing for you, as well as they can immobilize the legs, they can immobilize the pelvis. And if we happen to benefit a little bit from some of the, in theory, auto transfusion, great. So that theory that I mentioned, the concept is that it forces blood from the legs and the abdominal cavity and into the central circulation, and it helps to maintain perfusion of the vital organs. The patient in shock is really maximally vasoconstricted anyway, so if they are in shock, chances are they don't have a whole heck of a lot of blood left down there anyway. They've already shunted it. So this may also increase internal bleeding above the level of the PASG. So if you had a chest wound or a head wound, could potentially increase that bleeding. It puts pressure on the abdominal organs, which can then push up into the diaphragm, which can then push up against the thoracic cavity and cause some ventilatory impairment. Briefly, if we will look, draw your attention to page 933 in your textbook, we can take a look at some of the protocols for PASG. Some of the three major indications that they have is decompensated shock, where the patient has a systolic lower than 90. They have a suspected pelvic fracture with hypotension, or a suspected intra-abdominal hemorrhage with hypotension, so a AAA. They are contraindicated in several settings. The one and only one absolute contraindication to PASG is the first one, which is cardiogenic shock, or basically pulmonary edema of cardiac origin. So if we increase the pressures up against the heart, all we're going to do is cause them to have a worsening of their failure. They're going to get super, super wet lungs, and they're going to die. Abdominal evisceration is a relative contraindication. You could apply the legs and not pump up the abdomen. Penetrating thoracic trauma, again, you could do legs. You may, depending on what the actual injury is, if you have a impaled object in the abdomen, you would not want to inflate the abdomen, but if you had, say, a shooting, perhaps it would actually benefit you from helping to control a little bit of bleeding. Pregnancy, again, you could do legs, but you would not want to inflate the abdomen. Cardiac arrest is not going to benefit you. It's not going to benefit them. All it's going to do is create a lot more of an issue. It's going to be a bigger problem to get them on. So remember, once we've inflated them, we don't deflate them until we're advised by medical control, because there's going to be complications. There's the potential that we're going to run into complications after we've applied them, such as impaired ventilation. They may ask us to deflate these in the field. Chances are we're not going to be asked to do that until we get to the hospital. One thing I will tell you to keep in mind is most hospital workers have no idea what these are. They don't know how they work. They don't know how they're supposed to be used. Remember, the way that you inflate these is you'll inflate usually one leg or maybe both legs at the same time. Recheck the blood pressure, see if you're getting where you want to. Then perhaps go to inflate the abdomen. Some places say inflate all three at the same time. The process is you usually will inflate these until their blood pressure comes up above 90, or the Velcro starts to pop on them, or some of them have pop-off valves, which is an air pressure sensitive valve that it gets to a certain amount of internal pressure and it starts to let off the extra pressure in there. So once those start, one of those things occurs as usually the end point of inflation. Deflation, really, though, it needs to be one of those things that has to be done over time. They have to have IVs in place. Usually we're going to have some blood ready to go, and it's let a little bit of air off, say up the abdomen, recheck the blood pressure, recheck the pulse, make sure everything's good, let off a little bit more air, recheck the blood pressure, recheck the pulse, and it's just a constant back and forth between letting off a little air, rechecking vitals, letting off a little air, rechecking vitals. If somebody just goes in and rips those suckers off, there's a good chance that patient's going to all of a sudden have a real big container that they can't fill, and it's going to get real ugly. So additionally, keep our patients warm, keep them well oxygenated, ventilated, their airway open, IVs to an extent, control bleeding. That critical patient, hypothermia can be a fatal issue. So keep them warm. It's something that we can't stress enough. If you have the abilities to give warmed IV fluids, great. Can you use warm packs? Perhaps. Hypothermia is going to reduce the effectiveness of the body's clotting mechanisms and cause a coagulopathy. And coagulopathy reduces the body's ability to stop active bleeding, and then they just continue to bleed. So it really becomes just spiraling into the earth. It's nosediving. The patient just continues to nosedive. All right, so has anything changed in our case study since the beginning of the chapter? Remember that successful management of the multi-system trauma patient begins with the scene size up. We identify mechanisms, suspect any life threats. We're going to perform our primary assessment, systematic primary assessment. Something that I need to continue to emphasize in you guys is even the last skills day, we have to continue to work on developing our system and sticking to one system and one format of doing our assessments. Manage the immediate life threats, the ABCs, do a rapid trauma exam, followed by a head-to-toe as time and resources allow. Identify the injuries, manage appropriately in context to their overall condition. During our trauma resuscitation, first priorities are, again, ABCs, oxygenation, controlling external bleeding, maintaining a patient's body temperature, and attempting to keep a systolic blood pressure. Remember, permissive hypotension is okay. Maintaining a systolic blood pressure that's adequate enough to at least continue to keep fluid or keep the vital organs perfused. Our goal is a systolic blood pressure of 80 to 90 in most trauma patients, perhaps 100 in the head injury patient. And then minimizing our on-scene time while managing the ABCs has to continue to be one of our highest priorities. Transporting to the appropriate hospital via the appropriate means, depending on the circumstance, and do not delay the transport of a critical trauma patient to do the little things such as extremity fractures or IV access. Consider the use of aeromedical support. Consider the use of ALS or paramedics. Identify and manage any life threats and initiate transport at ASAP, and provide a rapid transport to a facility where the patient can receive definitive care. We should qualify that a rapid, safe transport. Remember, it doesn't do anybody any good to get halfway there really fast.